about contrast enhanced CT of the chest today, and we will try and see how we use intravenous contrast for evaluating various structures within the chest. Why do we use contrast? What is the basic principle of doing so? If you see here, on the left is a plain scan where you can't really differentiate the vessels from the lymph nodes or from any of the other structures in the mediastinum. On the right, the arrow points to the pulmonary artery, which is opacified by contrast, and the arrowhead shows the lymph node, which doesn't pick up the intravenous contrast to that extent and can be separately easily distinguishable from the pulmonary artery. So, since the vessels enhance differently, after giving contrast, we can separate out the vessels from the other structures in the mediastinum. Also, the pattern of enhancement, whether these are nodules in the lungs or lymph nodes, the patterns are different, and that also allows us some form of better tissue characterization. For example, the lymph node in the paratracheal region on the left shows homogeneous enhancement, which means it's non-necrotic, whereas the lymph node on the right shows necrosis. Only the periphery is enhancing, the rest of the node is not picking up the dye, as you can see in the rest of the vessels. And the presence of necrosis in the appropriate setting in our country often allows us to make a diagnosis of tuberculosis in the young patient, perhaps metastatic disease in the elderly, if the patient has a known primary. Dual energy scanners have allowed us to use contrast even better. Typically, we have two beams of different energies, perhaps at 80 kV or 120 kV. This allows us to use less radiation during the scan. It allows us to use lesser contrast. So, typically if we were using 80 to 100 cc to do a traditional CT scan, we can go down to 50 or 60 ml. We can do perfusion and permeability maps, and we can do tissue characterization, as I can show you here. So, here is one patient who has a nodule in the left midzone in 2016. It was there in 2013, but not there in 2010. And the question is this a benign lesion because it's not grown over 3 years, or is there a malignant potential? You can see the nodule very well visualized on this perfusion map, and if you see carefully, there is no enhancement at all. And we've done the iodine map here, and we do not see any evidence of iodine pickup within the nodule, telling us that this is almost likely to be benign, coupled with the fact that it's not grown over 3 years. And we're following up this patient, but this has been labeled to be a benign granuloma. So, we use intravenous contrast in all focal pulmonary lesions, in all mediastinal and vascular lesions, and pleural and rib lesions. We do not use contrast in patients where we are screening the lungs for metastatic disease, or for all the diffuse lung diseases, including your interstitial lung diseases, emphysema, etc. We are not going to talk about pleural and rib lesions today. Suffice to say that all of these present with pathology that usually requires contrast to either look at the visceral parietal pleura, the thickness, presence of nodules, or in rib lesions, the presence of abnormal soft tissue, necrosis, etc. Now, when we are looking at focal pulmonary lesions or focal mediastinal lesions, then the common things that we will look at are solitary nodule, lymphadenopathy, mediastinal lesions, non-resolving consolidation, and pulmonary thromboembolism. So, we will spend the next few minutes looking at each of these issues. Now, in the solitary pulmonary nodule, for example, this is a 52-year-old lady who comes for a routine health checkup. We can see a nodule in the right midzone here. And the question is, what would this be? So, we would do a CT scan, and on the CT scan we see a lobulated enhancing nodule in the right upper lobe. Now, what does this mean? Is this benign? Is this malignant? What do we do next? Well, here are the criteria for benignity. The criteria for benignity essentially would be the presence of calcification, the absence of enhancement or CT or uptake on PET, and no growth in 2 years. Now, if we look at the scan that we had taken, we find that there is enhancement. Now, if we find that a lesion is completely calcified, as you see here on the right, where there is a calcified nodule in the superior segment of the right lower lobe, then this is completely benign. On the right you see a mass and there is a calcific focus anteriorly that is marked by the arrow here, whereas there is a calcified granuloma which is engulfed by the rest of the mass, and therefore this is not benign. And we can't turn around and say that just because there is calcification in the lesion it is supposed to be benign. But look at this patient here where there is completely no presence of enhancement. There is complete absence of enhancement in the nodule that is seen in the posterior segment of the right upper lobe, and therefore this can be considered to be completely benign. Our patient not only has enhancement, also has growth over the last 2.5 months, and that tells us that this lesion is not definitely benign, or we use the term indeterminate. So, we look for the 3 definitive criteria of benignity, and I repeat, it is diffuse calcification, absence of growth in 2 years and absence of enhancement. Here we have enhancement, and that is the power of giving intravenous contrast, and there is growth. Therefore, this lesion needs to be further worked up. So, we biopsied the lesion and it turned out to be adenocarcinoma. In the mediastinum, contrast allows us to evaluate various structures and eventually helps us to come to a diagnosis. This is how we look at mediastinal lesions. We try and rule out a normal variant, then see whether it is focal or diffuse disease. If it is focal disease, see whether it is a vessel related problem, whether it is lymphadenopathy, and whether it is a mass. If it is lymphadenopathy or a mass, you need to biopsy it. And otherwise, if we are still not sure what is going on, then we would look for fat. We try to see whether it is a cyst, see where the lesion is, because that also helps us with coming to a diagnosis, and even then if we are not sure, we would go ahead and biopsy it. So, the approach is to rule out a vascular lesion, to see whether it is a node or a mass or a normal variant, and then if we still do not know what is happening, go ahead and biopsy it. What are the normal variants that we see? One of them is the thymus. After we give contrast, the thymus is seen separately from the rest of the vessels. This is a normal thymus. It is a little prominent, but would not be a cause for alarm, and that is how we would read this. We should know what happens to the thymus on successive scans at different ages. So, at the age of 2 years, the thymus is an extremely prominent structure in the mediastinum, but as the patient grows, the thymus does not grow. The rest of the chest grows, and therefore, the thymus seems to shrink. After the age of 25, there is fat infiltration within the thymus and you can barely see it, and generally after the age of 60, it would be completely atrophied, as we see here on the series of images. This is another normal variant, a patient who has superior mediastinal widening, which after giving contrast, the vessels are opacified and we can see tortuous innominate vessels, and nothing really further needs to be done. Similarly, after we give contrast, as in this patient who seems to have a mass in relation to the middle mediastinum or in relation to the aorta, when we look at the contrast study, it is a clear-cut aneurysm of the ascending aorta, and we have got the diagnosis based upon the appearance on the contrast study. We can also differentiate between lymph nodes and masses based upon the appearances, the anatomy and the contrast features. Nodes are typically discrete, multiple in specific locations. Individual nodes would be less than 5 centimeters in size and they produce displacement of structures around them. Masses are ill-defined, typically single, greater than 5 centimeters. They have no specific location and they encase and infiltrate. So, you can see here the arrows pointing out typical lymph nodes in the pretracheal space and right paratracheal region, the left para-aortic region. The right side image shows a subcarinal lymph node with a little air within. Again here you see lymph nodes in the subcarinal region and the left hilum, and this is a plain scan where you can still make out that there is abnormal lymphadenopathy, and we see lymph nodes in the right supraclavicular region on the image on the right. Masses are different. Now, here on the left is a mass that is encasing the left pulmonary artery in the hilar region along with effusion. On the right side, it is interesting, there is a lymph node in the pretracheal space and right paratracheal region, but in the left para-aortic region, we see a mass that is ill-defined. It is longer in the AP diameter than in the mediolateral diameter. It has a wide area of contact with the aorta. So, that becomes a mass, and that would typically be malignant. Here is another mass in the prevascular space that encases the SVC, involves the thymus, and this is malignant. And again, if you see posterior to the SVC is a lymph node in the pretracheal space and right paratracheal region. The right sided slide shows you a large mass again that involves the upper lobe of the lung, and again would be assumed to be malignant unless proven otherwise. Now, what do we do once we've picked up nodal disease? We try and look for necrosis, and necrosis is defined as the presence of lack of enhancement involving at least 75% or more of the volume of the node. And you can see that here where there is peripheral enhancement, but the rest of the node does not show any enhancement at all, as against the presence of non-necrotic adenopathy, as we see in the subcarinal region here, where there is predominant homogeneous enhancement that we have. How does that matter? Necrosis in the correct clinical setting, for example, an 18-year-old with fever and a necrotic lymph node would almost always be tuberculosis unless proven otherwise, whereas with non-necrotic nodes you can't tell, and therefore the imperative to biopsy non-necrotic lymph nodes becomes much higher than with necrotic lymph nodes. What about the other masses? So, once we've figured out that a lesion is not a vascular lesion, that it is not a lymph node, then we need to figure out what kind of mass it is. So, the internal characteristics of the lesion as well as the location of the lesion will help us. Now, for example, if you have a mass in the prevascular space as we see here, or in the anterior mediastinum, this particular lesion has a tooth within, has fat within. This we know is a teratodermoid. Whereas if you see a mass like this in the prevascular space that seems to be a little arrow shaped, and this is likely to be a thymic tumor. But a large mass like this in the prevascular space appears aggressive, appears malignant, but it is indeterminate. This could be a thymoma, it could be a germ cell tumor, it could be lymphoma, and short of a biopsy, we will not know what is going on. Thyroid tumors can go into the anterior mediastinum, and using good sagittal and coronal reconstructions as we see here, we can easily see the contiguity between the thyroid and the mass going into the mediastinum, and that gives us the diagnosis. Look at the lovely necklace created by the left innominate vein on the coronal image, and that obviously gives us the diagnosis too. Let's say you had a lesion in the posterior mediastinum. As we can see here, there is a lesion in the right paratracheal region. It shows a very sharp upper margin telling us that this is in the posterior mediastinum. On the plain scan, it is a little hyperdense and it does not enhance, which means that this is likely to be a cyst, and in the mediastinum this invariably lands up being a bronchogenic cyst. As against this patient, again a posterior mediastinal mass, and you can see a solid enhancing lesion in the right paravertebral region, showing typical characteristics of a neuroma. Having said that, we would still have to biopsy this to prove the diagnosis. This is a complex mediastinal lesion, and the CT scan shows that it is a collection. There is only peripheral enhancement as seen by the arrow. Not only that, you can see some amount of enhancement within the spinal canal. This is an abscess, and obviously the commonest cause would be a tuberculous abscess related to tubercular spondylitis, and that is how we are able to make the diagnosis. We would still have to put a needle inside, get the pus out, send it for culture sensitivity, etc. What about the medial costophrenic angle? Now, this is what a typical lesion in the medial costophrenic angle looks like. This is a Morgagni hernia. You can see that the liver is herniated through the foramen of Morgagni, and again the coronal and sagittal reconstructions would show that really well. The density matters. If you see the image on the left, it shows a lesser density than the image on the right as far as the medial costophrenic angle lesion is concerned. Now, the one on the right we have already seen is a foramen of Morgagni hernia containing liver, but the one on the left likely represents fat. So, it could be just a prominent epicardial fat pad, or it can be a foramen of Morgagni hernia containing omentum, and we can see here that this is a foramen of Morgagni hernia containing omentum. You can get a cystic structure here as we see in this patient, and this is a pleuropericardial cyst. You could have a lesion in the left posterior mediastinum. As we see here, there is a large lesion with an air fluid level, and if we look at the CT scan, it clearly shows us a large hiatus hernia where the stomach shown by the arrow has herniated into the thorax and was producing that air fluid level. So, to repeat, the use of contrast in the mediastinum allows us to rule out normal variants like the thymus and tortuous innominate veins. And in focal lesions, it allows us to look for vessel pathology. It allows us to differentiate lymphadenopathy from masses. It allows us to look at internal characteristics and decide whether the lesion is cystic or contains fat, etc. And then if we still have a dilemma as to what the lesion is, we can then do a CT guided biopsy. We can then move on to another use of contrast, and intrinsically if you want to look at the pulmonary vasculature, you need to give intravenous contrast. And if you are looking at pathologies like arteriovenous malformation that you can see here beautifully, we need to do a multiphasic scan both with pulmonary arterial and pulmonary venous images to define the feeding arteries, the draining veins, the nidus, etc. And then all of this pretty much would allow the interventional radiologist to treat this patient with coiling. So, this both allows us to make the diagnosis as well as to create the images required for planning treatment. The other pathology that affects the pulmonary vessels is thromboembolism, and this can be acute or chronic, and we know that in acute pulmonary thromboembolism, once the clinical call has been made to investigate a patient suspected to have PTE, we would need to do a CT angiogram. The use of contrast coupled with fast scanners, and that started with spiral CT scanners in the 90s, completely changed the way we approached the diagnosis and prognostication of pulmonary thromboembolism, and it created a paradigm shift so that today if we have a high index of suspicion for pulmonary thromboembolism, the first thing we will do is a CT angiogram as far as imaging is concerned. Now, with the faster scanners, with the dual energy scanners, we can use a reduced dose of 60 ml with a high concentration contrast of 370 milligrams per ml at an injection rate of 5 ml per second with automatic timing, so that we can get the pulmonary arterial phase and get such beautiful images where on the left you can see the RA and RV are opacified, on the right you have the MPA, RPA and LPA, and you can see the filling defects that are so beautifully picked up in contrast against the opacified vessels. And that is the beauty of doing a good CT pulmonary angiogram. If the study has been optimally done, the diagnosis is easy to make. So, we have direct signs where we see filling defects within the pulmonary arteries. There are a lot of names given. You have the polo mint sign that you can see on the left, where you have the thrombus as a filling defect in the center with contrast rimming the periphery. You can see the railway track sign on the right, where the thrombus looks like the tracks of a rail, and you can see the contrast on either side as well. The thrombi can have a saddle shape going from the RPA to the LPA, and you can have a thrombus that is en plaque, that is plaque like along the wall of the vessel This is more common in chronic pulmonary thromboembolism than acute cases, but you see it in acute situations as well. The indirect signs would essentially be infarcts, and you can see that infarcts can have different appearances. Typically, you see a wedge-shaped lesion, as you see on the right, within the lungs, and this patient has obvious lower lobe pulmonary thromboembolism. But infarcts can also show an appearance, as you see in the top row of images, where you have a bubble-like lucency seen on the mediastinal windows. This typically occurs because of some form of hemorrhagic infarction. And when we see bubble lucencies in a patient who otherwise does not have signs of definite infection or pneumonia, the first thing we think of is infarction, and that patient had thromboembolism. In subacute cases, an infarct may cavitate, as we see in the lower row of images. The HRCT shows us a cavitated lesion that could easily be mistaken for squamous cell carcinoma or tuberculosis, depending upon the setting, but the patient has classic pulmonary thromboembolism, and this is just a resolving infarct. In the past, we also used to do CT venography as an accompaniment to CT pulmonary angiography. But as a rule, this is not coupled with the study in today's day and age. We would still prefer to do an ultrasound color Doppler for the leg veins and restrict the study to the chest. But to show you what we used to do in the past, you can see here thromboembolism in the right lower lobe pulmonary artery in the upper row of images, and then you extend the study to the lower limbs and we can see a thrombus in the right femoral vein very well, and that kind of proves the point. But nevertheless, since eventually the follow-up of thromboembolism in the calf or thromba in the calf veins needs to be done on ultrasound and color Doppler, it's just a good idea to get that done separately. Now, given all of these abilities that CT angio has, how good is it? So, you can see that the sensitivity for central lesions approaches 100%, but it drops down to 70% for peripheral emboli for a variety of reasons. And similarly, the specificity approaches 100% for central lesions, but there is a significant overdiagnosis that does occur with peripheral lesions, dropping the specificity dropping to almost 50% if the lesions are solitary or subsegmental. And so, the higher the pretest probability, the better is the sensitivity and specificity, dropping considerably if the pretest probability is low. We can also prognosticate, and therefore all radiologists and physicians should be aware of what high risk, intermediate risk, low risk and no risk PTA is. But to prognosticate on CT, the most important thing is to look for RV dysfunction, and within RV dysfunction, the most important sign is to measure the RV-LV ratio on axial images, and if it's greater than 0.9, there is now robust evidence that it predicts an adverse 30-day outcome. Other signs that help are septal deviation, IVC contrast reflux, etc. So, let us see one patient who has pulmonary thromboembolism, and you can see on the left we have measured the right ventricle at its maximum diameter, and on another image we have measured the left ventricle on another in its maximum diameter, and the RV-LV axial ratio is 1.3, which is much higher than the normal less than 0.9, and suggests the possibility of an adverse outcome. In the image on the left, you can see that the septum is also deviated into the left ventricle, and you can see IVC reflux on this study as well, telling us that all the possible parameters that can predict an adverse outcome are present in this patient. What about dual energy CT? And we know that dual energy allows better appreciation of peripheral emboli. It also allows better appreciation of acute and chronic PE. We are now looking at quantification of blood volume that would likely help assess severity and help prognosticate. We need less contrast, and there is less radiation as well. So, here is a patient who has shortness of breath. We see large filling defects in both pulmonary arteries, and the perfusion maps that we create on dual energy scanners allow us to look at the extent of reduced blood flow that is there within the lungs, and as I said, eventually we can quantify this and then we can also prognosticate accordingly. We should also be able to pick up pulmonary embolism that is non-thrombotic, and therefore typically if we see some unusual morphology, enhancement of the thrombi, associated unusual lung findings, our antennae need to be up. So, here is a 42-year-old with marked acute onset dyspnea. The right lung shows an infarct, but on the left we see a nodule that is not an infarct, and this should raise our suspicion, especially when we see a lesion like this that is in the MPA extending into the RPA, but shows septae and shows heterogeneous enhancement. This implies that this is unlikely to be a thrombus. Our diagnosis was pulmonary artery sarcoma, and we biopsied the left lower lobe nodule that allowed us to make the diagnosis. What about pregnancy? Can we give contrast? Can we do a CTPA? But there are enough criteria out both by the ACR as well as the American Obs-Gynec Society, etc., that tell us that when a patient who is pregnant has suspected pulmonary embolism, the first thing to do is an ultrasound of the lower limbs. If we find significant thrombosis, we may not need to do any test for pulmonary thromboembolism, but in case we have to, then there is a debate of what should be done, whether it is lung scintigraphy or CTPA, but invariably it is a good idea to do a CTPA because you can see the thrombus, the emboli, we can do severity assessment, and it is much easier, quicker and simpler to do. Most importantly, both IV contrast and radiation are safe for the mother and the fetus, and therefore CTPA can be done. Ideally should be done on a dual energy scanner, so you can use less contrast and give less radiation to both mother and fetus. So, what about radiation issues? We know that when we do a CTPA, the radiation is 400 times that of an X-ray, comes to about 2 to 11 millisieverts, but this is much less than the radiation required to create a stochastic mutation. That typically would be in the range of a one-time exposure of 50 to 100 millisieverts, which is not what we are giving, and there is no cumulative effect of radiation in case you have to do multiple scans. At the same time, we are now working with less radiation on the newer dual energy scanners, and essentially radiation exposure is not an issue as far as CTPA is concerned. Now, what about chronic pulmonary thromboembolism? We know that it is a complication of acute PTE because of non-resolution of the fibrothrombotic obstructions, but the prevalence varies from 0.4 to 9.1% depending upon the study. Having said that, if we have a high index of suspicion clinically, it is not difficult to make the diagnosis if we look at all the signs that we have on CT. The first is a mosaic perfusion that we see on CT of the lungs, where we see alternating white and black areas. We do inspiratory, expiratory images. The image on the left is inspiratory, the image on the right and at the bottom is expiratory. And we will not see air trapping. The white areas will see a lot of vessels within, and that should give us a clue that we are dealing with chronic pulmonary thromboembolism. The MPA invariably will be dilated as well. In that setting, it is a good idea to then do a CTPA. So, here is another patient who has a mosaic pattern in the lungs, and the CTPA shows a web in the right upper lobe, complete occlusion of the left pulmonary artery, findings that suggest that this is all chronic pulmonary thromboembolism. We can also see other signs of PH, and when that happens, again we can make the diagnosis well. So, here is the MPA dilated in the same patient, on the right we see RV dilatation in the same patient, all findings that combined together help us make the diagnosis. And with dual energy CT, we are able to pick up perfusion defects as well. So, subtle mosaic pattern better appreciated in the left lung in this patient.
We see webs, stenoses and thrombi within. So, on the right we see a linear filling defect in the RPA. On the left we see complete occlusion of the distal lower lobe pulmonary artery and then no vessels beyond as well. And the perfusion scan shows us these large perfusion defects on the right, fewer on the left, but it is on a single image that we are seeing this, and confirms the presence of pulmonary thromboembolism. So, if we were to just look at pulmonary thromboembolism, we can look at both acute and chronic PTE. CT allows us to make the diagnosis, do severity assessment, and dual energy CT is better than single energy scanning. We can make a diagnosis of chronic PTE based upon findings on both the lung CT as well as the CT pulmonary angiogram, and that is how contrast, the use of contrast makes such a difference in the evaluation of pulmonary thromboembolism. Lastly, we look at non-resolving consolidation. Now, the typical causes of non-resolving consolidation would basically involve unusual infections, infarction, neoplasm and sometimes sequestration. Now, here is a patient who presented with mild dyspnea on exertion and chest pain. We did a CT scan and the CT scan shows bubble lucencies on the lung window images on the left as well as the mediastinal windows on the right. And the moment we see bubble lucencies on mediastinal windows, I told you earlier that this should raise the index of suspicion for an infarct. Of course, you can also get this with bad infection, but this patient had no signs of infection. So, after seeing this, we then did a CTPA and we found that the vessel leading to that bubble lucency lesion had an embolus within, right. So, this is a subsegmental embolus causing a focal lesion that is non-resolving with bubble lucencies, which actually turned out to be an infarct. And lastly, we have this 23-year-old with recurrent right lower lobe infection, being treated with antibiotics, had received one course of AKT, going from physician to physician for the last couple of years, finally landed up with us during an acute episode of infection. She's got cystic areas, air fluid levels and all of that, and we had a high index of suspicion for sequestration because it's a right lower lobe lesion, and you can clearly see on the CT angiogram that there is an anomalous vessel from the abdominal aorta that is supplying this lesion. So, this is intralobar sequestration, has had multiple episodes of infection and then easily diagnosed on the basis of the CT angio finding, right. So, in all patients with non-resolving consolidation, the use of contrast again is typically to look at the vessels, whether it is to pick up occult thromboembolism in infarcts that look like non-resolving pneumonia, or in patients with sequestration that have been missed for let us say many months or years, where we can then pick up the anomalous vessel to arrive at the diagnosis. So, what we have done in the last few minutes is looked at the use of contrast in the chest, and we have looked at solitary pulmonary nodule. To recap, the presence of enhancement in a nodule means it could be an active granuloma or a neoplasm. It makes it indeterminate and typically implies the need for a biopsy. The absence of enhancement is an extremely powerful sign that would tell us that this is either a cyst or an old granuloma and can be left alone. Lymphadenopathy and the mediastinum, the use of contrast allows us to further characterize mediastinal lesions, right. So, we can pick up lymph nodes separate from masses, we can pick up vessel lesions, we can rule out normal variants like the thymus and tortuous anominate vessels as we have shown. And then if we still are stuck for an answer, we would go ahead and do a biopsy. Similarly, pulmonary thromboembolism and non-resolving consolidation are situations where we need to use the power of giving intravenous contrast to opacify the vessels well. When we do that,
We can then diagnose pulmonary thromboembolism, prognosticate, differentiate acute from chronic, and do a lot of things that make a huge difference in the management of patients. And similarly, looking at the vessels allows us to pick up occult infarcts or occult pulmonary thromboembolism masquerading as non-resolving consolidation, as well as patients with sequestration. Thank you for your attention.